Hey guys, this is Dr. Shivam and we'll start with another session on ECG. Before it, one thing to remind you that the world never stops moving on its way. They applaud if you win, criticize if you lose. You detached or attached, it doesn't matter. Just keep moving on your purpose, the world will follow you. So, the same advice to you, don't stop reading, don't stop studying till you get over your AIIMS and PGI examination. Another thing, whatever you do whole day, don't get stuck on one thing that ruins your day. So forget your all the negative thoughts, smile and be grateful for your life, whatever you have got in this life, because it is too short to waste on negativity. So we'll start with our ECG session, and for basic ECG I have already made one video. You can go through it if you find it difficult for this video, because we are just going to discuss some important question which will give you extra confidence in solving ECG questions, because I found that ECG is something which most of you have fear in it. So don't get fear seeing the ECG question, just have some basic concept and I believe you will be able to solve every question of ECG. And nowadays they are giving ECG question, not only one but 3-4 ECG questions. So your NeetPg also had, and your coming AIIMS in PGI will also have ECG question. Now tell me, in this question, a patient develops this condition intraoperatively, what will be the drug of choice for this patient? Now if you observe this ECG carefully, it is basically a intraoperative tachycardia. Okay, so what among these, what you can give? So among it, propranolol seems to be perfect one, because it decreases the heart rate, force of contraction and prolongs systole. Okay, so by this total coronary flow will get reduced, and will mean the main purpose is to decrease the heart rate, which it will do by retarding the conduction, so that synergy of the contraction of ventricular fiber is disturbed. So answer here will be propranolol. Now this is something very characteristic ECG. Now tell me the drug of choice for this congenital disorder. So first you have to identify what is it. It is Torsades de Pointes. So most of you must have been knowing this, but tell me the drug of choice, the treatment of choice of acquired Torsades de Pointes. So for acquired, it is intravenous magnesium. And the second question which is asked regarding it is prophylaxis. So for prophylaxis of this Torsades de Pointes, we give beta blockers. Among it, propranolol is the most commonly or extensively used, followed by esmolol. So among these four options, none of them is the answer, because drug of choice is magnesium, intravenous magnesium. Now drug of choice for termination of disorder shown in ECG is, so first you have to identify what is the condition here. So it is basically, it is basically a PSVT, supraventricular tachycardia. So what will be the drug of choice? It is adenosine, a class 5 arrhythmic drug, anti-arrhythmic drug. Okay, so short life, if I ask you the T half of this adenosine is, so it is 10 seconds, and it leads to hyperpolarization of AV node by opening up potassium channels. Other class 5 anti-arrhythmic drugs are magnesium and digoxin. So the answer here is adenosine for termination of PSVT. Now diagnose this condition and then tell me the drug of choice for this condition. So here what you can see, basically the ventricular, that is the QRS patterns are disturbed and it is very high, that is it is the ECG of ventricular fibrillation. Now you all know that the lidocaine is the drug of choice or the agent of choice for termination of ventricular tachycardia and prevention of ventricular fibrillation after cardioversion in setting of acute ischemia. So lidocaine is the answer here with a half-life of 1 to 2 hours. They can also ask this half-life. Now tell me the drug of choice for acute condition shown in this ECG. Now here what you can observe is widened QRS complexes along with tall dented T waves. Now what can this condition be? Yes, it is hyperkalemia and calcium gluconate 10 ml in 10% solution of, means intravenously you will be giving calcium gluconate, 10 ml in 10% solution of calcium gluconate. Okay, so this is the drug of choice for this hyperkalemia. Now they have given you one condition, that is a 76-year-old male came to emergency with complaints of retrosternal pain for 6 hours. So here the duration is important because the management depends upon the duration. Following is the ECG. Tell me the next line of management for this patient. Now you have to observe the ECG, find out the typical finding which they want to represent here, and this ECG is of acute MI, showing you the ST elevation and all. So the management of acute MI depends upon the time duration in which the patient presents to you. So there is one algorithm or the synopsis for management of acute MI. I will summarize it for you. Now if a patient presents to you, first you divide it in two. A patient presents to you in symptom less than 2 to 3 hours of start or onset of his symptom, and the second one who present greater than 2 to 3 hours of onset of symptom. Now the first category in which the patient is presenting in less than 2 to 3 hours of onset of symptom, if for him, if the transport time is less than 30 minutes, you do the primary PCI. Okay, so you transfer the patient for primary percutaneous intervention if the transport time is less than 30 minutes in a patient presenting within 2 to 3 hours of the onset of symptom. If the transport time is greater than 30 minutes, then you go for the thrombolytic therapy for those patients who are eligible for thrombolytic therapy. Now the second category in which they are presenting in greater than 2 to 3 hours of onset of symptom, for them if the transport time is less than 60 minutes, then you again go for primary percutaneous intervention. But if the transport time is greater than 60 minutes, you go for thrombolytic therapy. Okay, so here the patient is presenting after 6 hours, that is greater than 2 to 3 hours, and they haven't mentioned what is the transport time. Then you may say the question is not complete. In this case it can be both. If the transport time is less than 60 minutes, you will go for primary percutaneous intervention. If it is greater than 60, you will go for thrombolysis or primary PCI. But here if the same question comes, you will choose primary percutaneous intervention because it is much better one than the thrombolytic therapy. The second question, coming to the second question, here a 52-year-old diabetic patient complains of palpitation, ECG is given, the first line of management. So here you can see some very narrow complex tachycardia, most probably supraventricular tachycardia. Okay, so to identify them you may go to my previous ECG video because some of you may find it difficult. So for narrow complex tachycardia, basically supraventricular tachycardia, and if I ask you, the most common one is PSVT. So you will go for adenosine, which is the drug of choice for PSVT. Now in this diagram you have to identify what is the pathology and then tell me how you can differentiate it from others. So this is basically ECG of atrial fibrillation. Why I am saying it fibrillation or not and not atrial flutter? Because first you have to see it is not a ventricular pathology because QRS waves are normal. Okay, now whether it is a fibrillation or flutter, you can see here that there is disorganized, rapid and irregular atrial activation. Okay, another thing is the RR interval is varying. See here narrow, here wide, then narrow. In flutter it is constant. In fibrillation there is RR variation. Okay, and it is disorganized, rapid and irregular atrial activation, while in flutter the rhythm is normal, the RR interval is normal. Okay, so it is basically a ECG of atrial fibrillation and not flutter. Flutter will have sawtooth pattern and F waves replacing P waves and the RR interval will be normal. Now tell me this one. Okay, so here you can see the PR interval has been prolonged but the RR interval is constant. This means this is ECG for first degree heart block where the PR interval is more than 200 milliseconds. I have explained it in the previous ECG video. You can go through it. Diagnose an underlying medical condition by the ECG. So they have already mentioned it as prolonged QT interval. So which condition among it does this? So you all know that hypocalcemia typically prolongs QT interval, whereas hypercalcemia shortens it. So the answer here is hypocalcemia. Now this is very peculiar ECG showing you peaking and tall tenting T waves. So this is basically a ECG of hyperkalemia, which begins with narrowing and peaking or tenting T waves, tall T waves. Okay, so this is very peculiar, very easy one, and you should identify it at any cost. So severe hyperkalemia causes these type of waves, and they may later cause sine wave pattern followed by asystole. So it is very dangerous also. You need to control it at any cost. So diagnose this one, whether it is left atrial enlargement or right atrial enlargement. So very easy. You can see here the P waves are very long. That is, the amplitude of P waves is greater than where it went. Yeah, so the amplitude of P waves are more than 2.5 small squares. This means the P wave is P pulmonale, and it is right atrial overload or right atrial enlargement, and not left atrial overload or enlargement where you will see biphasic P wave. Okay, so right one, because it is P pulmonale greater than 2.5. The height is greater than 2.5 and not the width. Width will be greater in left atrial enlargement. Now diagnose me this one, because I have already told you about atrial fibrillation and flutter. Okay, so this one is disorganized with varying RR interval. So this one is atrial fibrillation. The QRS is normal, so no need of thinking for means ventricular pathology. It is atrial one with atrial fibrillation. The RR is not constant, and you can see some disorganized, rapid, irregular atrial activation. Now tell me this one, where the RR is constant and you can see sawtooth pattern, so typically of atrial flutter. This one is just a sinus tachycardia. Why I am saying this? Because the heart rate here is just, you can see it is around 150, and the PQRS, all the waves are present. P is followed by QRS and QRS is followed by P. So everything is normal except the rate has increased, so it is sinus tachycardia. Now identify me this one. So this is typical PSVT, and most common supraventricular tachycardia is PSVT with AV node re-entry. It occurs in 60% of patients with supraventricular tachycardia. Rate here will be 160 to 200, regular QRS complexes as you can see, and P wave will be hidden in QRST complexes. Okay, so this is, again you all know कि this one is torsade D pointis, but what here they are asking? So they are saying कि condition shown in photograph is not found in. So among these four, so this torsade D pointis is very important for you. You should know that it is a form of ventricular tachycardia in which the QRS morphology twists around a baseline, and these may occur in hypokalemia, hypomagnesemia, or administration of drug causing prolonged QT interval. So in comment section you will comment me कि which all drug cause prolonged QT interval, because they may cause torsade D pointis, and again they may ask you this. So here the answer will be hyponatremia, because it doesn't cause this torsade D pointis or prolonged QT interval. So this is very beautiful one. Now tell me the best line of management for this condition. So showing you a typical ST elevation, that is acute myocardial infarction, and the best treatment strategy is to prevent the development of cardiogenic shock with aggressive reperfusion therapy. So the answer here is reperfusion therapy. Okay, so this one is tall and peaked T waves in at least 2 contiguous leads provide an early sign of myocardial infarction and may precede ST elevation. Now tell me this one, the wider duration of ECG wave. So it is just showing you कि the QRS complex is widened and wants to ask you कि how much it will be. So normally they are said to be wide if it is greater than 0.12 second, that is greater than 3 small squares, which is the normal value. So you should also know the normal values of all intervals, which is already told in previous ECG video. The arrow here is showing you abnormally increase in U wave amplitude, and it is most commonly due to some drugs like dofetilide, amiodarone, sotalol, quinidine, procainamide, diisopramide, and due to hypokalemia. So among it, the answer here is hypokalemia, which prolongs the ventricular repolarization and often shows you the prominent U waves. So very typical of hypokalemia. Now this is something applied. ECG changes in tachycardia are seen maximum in which antidepressant drug? Now you should know the amitriptyline has maximum CVS changes or adverse effects like postural hypotension, dizziness, hypertension, sinus tachycardia, premature atrial and ventricular beats, antiarrhythmic effects, myocardial depression, pedal edema, ST depression, T-wave flattened, and many more. So here the answer is amitriptyline. Now the prolongation of segment shown in the photograph is due to, now they are basically asking you that the QTC interval is becoming prolonged. So it is associated with thioridazine. Okay, so this drug is associated with causing torsade de pointes or prolonged QT interval. That's why I said you to write the prolonged QT interval drugs in the comment section. So I think I have discussed most of the important ECG questions. One more is left. Now tell me this is a ECG of hyperkalemia, ECG changes. Now tell me which one you will not find in hyperkalemia. So in hyperkalemia you will find prolonged and abnormal QRS complex, tall tented T waves, wider QRS, but never inverted T waves, because we are finding tall tented T waves. Okay, so T wave inversions will be seen in hypokalemia but never in hyperkalemia. So I think I have discussed some of the important ECG, and it will help you to regain confidence in the ECG. And till then, stay happy, study hard, stay motivated, and be happy. Thanks a lot, guys. This is Dr. Shivam signing off.